There is a question millions of men type into search bars late at night, alone, hoping no one is watching. It is not a question about career or finances or family. It is something quieter than that, something more personal. And for most of them, the answer they find online is overwhelming, confusing, or buried under so much marketing that it becomes impossible to know what is actually true. That question is this: which erectile dysfunction medication actually works, and which one is right for me? Today, that question gets a real answer. Not a sales pitch. Not a list of brand names with price comparisons. A genuine science-backed exploration of what these medications are, how they work inside the body, what the research actually says when you dig past the headlines, and why the choice between them is more nuanced and more personal than most doctors have time to explain in a 15-minute appointment. By the time this video ends, you will understand your options better than most people who have already been prescribed one of them. Let's start with something that almost nobody talks about when this topic comes up. Erectile dysfunction is not a single condition. That framing matters enormously because it shapes everything, including how well any given medication works for any given person. For some men, it is primarily a blood flow issue rooted in cardiovascular health. For others, it is tied to hormonal changes, particularly declining testosterone. For a significant portion, it is neurological, a disruption in the signaling pathway between the brain and the body. And for many, it is psychological, driven by anxiety, stress, or a cycle of performance worry that feeds on itself in a way that becomes very hard to break. The medications we are about to discuss work specifically on one part of that picture, the blood flow side. Understanding that from the beginning helps explain why they work beautifully for some men and feel incomplete for others. It also explains why lifestyle, mental health, and overall cardiovascular fitness are not separate from this conversation. They are central to it. Now let us talk about the 4 medications that matter most in this space, because most of what you find online covers 2 of them and glosses over the others in ways that leave real gaps in understanding. The 4 are sildenafil, which most people know as Viagra, tadalafil, sold as Cialis, vardenafil, known as Levitra, and avanafil, which goes by the brand name Stendra. All 4 belong to a class of drugs called PDE5 inhibitors. That name sounds complicated, but the mechanism is actually elegant in its simplicity. Inside the smooth muscle tissue of the penis, there is an enzyme called phosphodiesterase type 5, or PDE5. This enzyme breaks down a molecule called cyclic GMP, which is what keeps blood vessels relaxed and open. When PDE5 is too active, it breaks down that molecule too quickly. The blood vessels constrict, and blood flow becomes insufficient for a firm erection. What these medications do is block PDE5, allowing cyclic GMP to accumulate, blood vessels to stay relaxed, and blood flow to increase significantly. But here is what most explanations leave out. This mechanism only activates in the presence of sexual arousal. These are not drugs that produce erections on demand without stimulation. They enhance a biological process that is already trying to happen. The nervous system still needs to send the right signals. The arousal still needs to be real. The medications simply remove a specific biological barrier that has been getting in the way. That distinction matters not just scientifically, but psychologically. Many men report that knowing the medication is in their system reduces the anxiety that was itself contributing to the problem. For them, the medication is not just physical, it is a psychological reset, a way of breaking the anticipatory worry loop long enough for normal function to return. With that foundation in place, let us look at what the research actually says when these drugs are compared head-to-head. One of the most comprehensive analyses of this question looked at data from more than 80 clinical trials involving over 47,000 men evaluating efficacy, alongside more than 70 additional trials with 20,000 men examining safety profiles. The scale of that data matters. This was not a small study or a single manufacturer's trial. This was a systematic look across the scientific literature. Here is what emerged. At standard starting doses, the doses most men are initially prescribed, sildenafil at 50 milligrams produced approximately a 47% improvement in erectile function scores compared to placebo. That is a meaningful number. Vardenafil at 10 milligrams came in around 35%. Tadalafil at 10 milligrams showed roughly 33%, and avanafil at 100 milligrams was around 29%. At face value, that makes sildenafil look like the clear winner. But the story does not end there, and in fact, the next part of the data is where the real decision-making begins. Side effect rates told a very different story. Sildenafil at 50 milligrams had the highest overall side effect rate of the group. Approximately 18% of men in the trials reported at least one significant side effect. Tadalafil at the same starting dose had the lowest, around 10%. The most common complaints across all four medications included headache, facial flushing, nasal congestion, and gastrointestinal discomfort. These are related to the vasodilatory mechanism, essentially the blood vessel relaxing effect that makes these drugs work also affects blood vessels elsewhere in the body, which produces those symptoms. What this means in practical terms is that sildenafil has an edge in raw efficacy at standard doses, but it comes with a higher burden of side effects. Tadalafil is slightly less potent on paper, but significantly better tolerated by most men who use it. That trade-off is not theoretical. It is something that shows up consistently in real-world prescribing patterns and patient satisfaction data. There is another dimension to this that matters just as much as efficacy scores, and it is the one most people ask about even if they do not phrase it in medical terms. How long does each medication actually work? Sildenafil typically becomes active within 30 to 60 minutes after taking it. Its window of effectiveness is roughly 4 to 6 hours, though individual variation is significant, and factors like food intake, particularly fatty meals, can delay absorption and reduce peak effectiveness. This is one of the practical things that often catches men off guard. Taking sildenafil after a heavy dinner and then wondering why it seems to work less well than it did before. Tadalafil behaves differently. It takes slightly longer to reach peak concentration in the bloodstream, often 1 to 2 hours, but its half-life is dramatically longer. The medication remains biologically active for up to 36 hours after a single dose. This is why it is commonly referred to as the weekend pill. A man can take it on a Friday evening and still have improved erectile response Saturday and Sunday without the pressure of timing a pill precisely before intimacy. This duration difference has a meaningful psychological dimension as well. One of the more subtle stressors related to erectile dysfunction and its treatment is the awareness of a clock. Knowing that a medication is working and then watching that window begin to close can itself create anxiety that undermines the very benefit the medication provides. Tadalafil, with its extended window, removes a significant portion of that pressure for many men. Tadalafil is also the only medication in this class with an approved daily dosing regimen. At 5 milligrams taken once daily, it creates a steady baseline concentration in the body. This approach does not produce the same kind of peak and valley response as on-demand dosing. Instead, it supports consistent improvement in underlying blood vessel tone over time. Research suggests that long-term daily low-dose tadalafil may actually improve natural erectile function gradually, not just during the window when the drug is active. The hypothesis is that sustained PDE5 inhibition, combined with the increased physical activity and improved self-confidence that often accompanies treatment, promotes better endothelial function, which is the health of the cells lining blood vessels, over weeks and months of use. Now let us spend some time on vardenafil and avanafil, because these two tend to get overlooked, and in some cases unfairly so. Vardenafil, or Levitra, is structurally similar to sildenafil and has a comparable duration of action, roughly 4 to 5 hours. Some men who do not respond well to sildenafil find that vardenafil works better for them, and the reason is likely pharmacological variability. Small differences in how different people metabolize these compounds can make one more effective in a given individual, even when population-level data shows equivalence. It is also worth noting that vardenafil appears to be somewhat less affected by food intake than sildenafil, which may matter for men whose lifestyle makes it difficult to time dosing on an empty stomach. Avanafil, or Stendra, is the newest of the four, and in some ways the most pharmacologically refined. It has the fastest onset of the group, with some men reporting effects within 15 to 30 minutes, which is meaningfully faster than any of the others. It also has a higher selectivity for PDE5 relative to other phosphodiesterase enzymes in the body, which theoretically means fewer off-target effects, including the visual disturbances like blue-tinted vision that some men experience with sildenafil due to that drug's mild activity at PDE6, an enzyme found in the retina. The main drawbacks of avanafil are practical rather than medical. It is the most expensive of the four, and depending on geography, significantly harder to obtain. For men who prioritize spontaneity and want the fastest onset with minimal systemic side effects, it is worth discussing with a physician, even if it requires a bit more effort to access. One thing worth examining carefully is the intuitive belief that a higher dose must produce better results. The data on this is genuinely surprising to many people. When researchers looked at what happened when sildenafil was increased from 50 to 100 milligrams, the improvement in erectile function scores was minimal. The difference was statistically marginal, while the side effect burden increased meaningfully, the same pattern repeated with the other medications. This suggests that in many cases, the standard starting doses are already near the plateau of the dose-response curve, and the incremental benefit of going higher is not as large as the increase in side effects and risk might suggest. There is an important biological reason for this. The PDE5 inhibition needed to produce the therapeutic effect does not scale linearly with dose beyond a certain threshold. Once enough of the enzyme is blocked to allow cyclic GMP to accumulate, adding more of the drug produces diminishing returns. Higher doses can still make sense for men who genuinely did not respond at standard doses, but automatic dose escalation is not supported by the evidence as a general strategy. This is also a good moment to address something that exists at the intersection of physiology and psychology, and that is the role of expectations in treatment outcomes. Clinical trials consistently find that a significant percentage of men in the placebo arm, men who receive no active medication at all, also report meaningful improvements in erectile function. The numbers vary across studies but are often substantial. This is not a footnote or a curiosity. It tells us something fundamental about the condition and about the treatment. Erectile function is deeply intertwined with the nervous system's assessment of safety, threat, and readiness. Anxiety activates the sympathetic nervous system, which is the fight or flight branch. That activation is fundamentally incompatible with the parasympathetic state required for erection. When a man believes that he has taken something that will help him, whether or not it is pharmacologically active, that belief itself can reduce sympathetic activation enough to allow normal function. This is not weakness or imagination. It is the body responding to a changed mental model. The medications work through genuine pharmacological mechanisms, and the evidence for their efficacy is robust. But this psychological dimension explains why the same medication, at the same dose, produces dramatically different outcomes for different men, and why addressing anxiety, stress, relationship dynamics, and self-perception alongside medication is not optional, but clinically meaningful. There are also lifestyle factors that directly affect how well these medications work and how much the underlying condition will progress over time. Erectile dysfunction is widely recognized in the medical community as an early warning system for cardiovascular health. The blood vessels that supply the penis are smaller than coronary arteries, and they often show signs of endothelial dysfunction earlier. This means that erectile difficulties in men under 50 can sometimes be among the first detectable signs of broader cardiovascular risk, years before a cardiac event might occur. This connection cuts both ways. It means that taking a pill without addressing blood pressure, weight, physical activity, and metabolic health is managing a symptom while leaving the underlying process untreated. But it also means that improving those factors genuinely improves erectile function, sometimes substantially, not just because of better blood flow, but because cardiovascular fitness and endothelial health are foundational to the biology of erection. Men who lose significant weight, begin regular aerobic exercise, improve their sleep, and reduce chronic stress do not always need to increase their medication dose. Sometimes they find they need it less. Sleep is a particularly underappreciated factor in this conversation. During REM sleep, men typically experience multiple nocturnal erections. This is not incidental. It is the body's maintenance protocol, a way of keeping penile tissue oxygenated and healthy. Sleep deprivation, sleep apnea, and poor sleep quality disrupt this process and have been linked in research to both testosterone suppression and impaired erectile function. Treating sleep apnea, for example, has been shown in some studies to produce meaningful improvements in erectile function independent of any medication. Alcohol is another factor worth understanding clearly rather than through generalization. Moderate alcohol consumption appears to have minimal impact on erectile function, and in some men may reduce performance anxiety enough to be mildly beneficial. But heavier use is consistently associated with both acute and chronic impairment. Acutely, alcohol is a central nervous system depressant that blunts arousal signals. Chronically, heavy alcohol use damages peripheral nerves, affects hormone metabolism, and disrupts sleep, all pathways that compound erectile difficulty over time. There are two safety considerations that require direct and unambiguous mention because they relate to potentially serious medical risk. These medications are vasodilators. They relax and widen blood vessels. If a man is taking nitrate medications for heart conditions, such as nitroglycerin or isosorbide mononitrate, combining them with any PDE5 inhibitor can produce a severe, potentially life-threatening drop in blood pressure. This interaction is not a theoretical concern. It is an absolute contraindication. Anyone using nitrate medications should never combine them with these drugs, and any man with a significant cardiac condition should have an honest conversation with a physician about whether sexual activity itself is medically appropriate before considering any treatment for erectile dysfunction. The second point is simpler but equally important. These medications are not appropriate for self-diagnosis and self-prescription. They are available through legitimate channels that require physician oversight for good reason. A doctor evaluating erectile dysfunction is not just writing a prescription. They are assessing blood pressure, ruling out hormonal causes, reviewing medication interactions, and sometimes uncovering cardiovascular risk factors that need attention. The medication is often the smallest part of that encounter. If we step back and look at the full landscape of what these four medications offer, a clearer picture begins to emerge. Sildenafil remains the most studied, the most prescribed globally, and the most pharmacologically potent at standard doses. Its limitations are primarily around duration, food interactions, and a somewhat higher side effect burden. For men who want a reliable, well-understood on-demand medication and can tolerate those trade-offs, it remains an excellent first-line option. Tadalafil offers the longest duration of any option in the class and the lowest side effect rate, with the added flexibility of daily dosing for men who prefer that approach. For men in relationships, men who find timing pressure stressful, or men whose work or lifestyle makes spontaneity important, it is often the preferred long-term choice. Its slightly lower efficacy at the same dose is often irrelevant in practice because effective dose management and the reduction in anxiety from its extended window frequently produce outcomes that match or exceed sildenafil in real-world use. Vardenafil is a reasonable alternative for men who do not respond adequately to sildenafil or who have specific concerns about food interactions. It occupies a similar pharmacological space without offering dramatic differentiation, but that is sufficient for the subset of men for whom it works significantly better. Avanafil is the fastest acting and most selective, making it theoretically the cleanest pharmacological option. Its practical inaccessibility and higher cost limit its use, but for men with the means and access, it represents the most advanced pharmacological refinement in the class. None of these medications is universally superior. The right choice is the one that matches an individual's lifestyle, tolerability preferences, relationship context, and underlying physiology, evaluated in conversation with a physician who understands the full picture. What tends to get lost in online comparisons and marketing is that these medications are tools, not solutions. A tool in the hands of someone who understands how and when to use it can produce remarkable results. The same tool used without that understanding, without addressing sleep, stress, cardiovascular health, and psychological factors, will always produce less than it otherwise could. There is something worth saying at the end of all of this that goes beyond pharmacology. The topic of erectile dysfunction carries a weight that is entirely out of proportion to the medical reality of the condition. It is common, it is treatable, it is often reversible, and it is almost always connected to other aspects of a man's health that deserve attention regardless of how any given prescription works out. Yet the silence around it is profound. Men delay seeking help for years. They minimize the impact it has on their relationships and their self-perception. They absorb enormous unnecessary suffering simply because the conversation feels impossible to begin. Understanding the biology of this condition, really understanding it, has a way of removing some of that weight. The PDE5 enzyme does not know anything about masculinity or identity. It is just a molecule doing its job in the body's signaling system. When that system needs support, reaching for science-backed help is not a statement about who you are as a person. It is a decision to pay attention to your body and take care of it with the same seriousness you would bring to any other health concern. The men who tend to do best, not just with these medications, but with their health overall, are the ones who treat this as an entry point rather than an end point. They ask their doctors questions, they look at their cardiovascular numbers, they improve their sleep, they address the anxiety they have been carrying. They come to understand that physical and psychological health are not separate systems that occasionally interact. They are the same system responding to the same conditions every single day. That is what the research consistently points toward, not a specific pill taken at a specific time, but an ongoing relationship with your own biology, curious, engaged, and unafraid of what you might find when you look honestly at what your body is trying to tell you.